conform to the tear, and move adequately because you don't want it to be too steep. You want it to move. And every time you move, there's a tear exchange. Okay? And can flush debris. Okay? But should cover the cornea at all times because, of course, the contact lens has that power that would rectify the error of refraction. That's why. So again, it must produce good stable vision, provide pretty basic. This is self-explanatory, but this is I want you to understand. This is what we call the Cartesian method. The Cartesian coordinates is just y and x. Y is the vertical and x as horizontal. Y is positive if it's superior. Inferior, it's negative. Okay? Clear so far, Randale? Okay, x is negative if it's temporal, plus x is nasal. So far, so good? Okay, and then what we have is the binasal. The binasal is exactly Cartesian. Only difference is it's done on both eyes. So your reference is both eyes. So still nasal is always plus. So your nasal is plus, your superior is plus, your negative is temporal and inferior. That's your temporal. So this one here, as you can see, there's a decentration. For the one over the left, you can see it says L, wherein the contact lens is decentered. So if that's the nasal, this is temporal superior. So you have uh, a Y plus and an X negative. Correct? Do you understand that? Do you follow? Good. So this is how you would describe it. For example, right eye descended nasally by zero point 0.5 millimeters. That's how you will record, especially in the lab. Okay. Left eye descended temporally because again, the nasal is represented by your prism. That's your nose. Okay, so left eye is descended temporally by zero point 0.5 millimeters and up by zero point 0.5 also. Okay, clear on your end. Okay, so if there is one thing, is the fitting descriptions. Under fitting descriptions, there's only three things you have to understand. Number one is the ideal, the good, and the optimum. That is a perfect. There's no perfect fit, but this is close to what you want. So this is what you want, the kind of fit. And then there's two other fit, which is you don't like. A steep, which is tight and bound, or a flat that is loose and mobile. It moves a lot. Correct? Okay, low riding is when the contact lens is inferiorly located, high riding, superiorly located, and then that's self-explanatory. You're good on that. So what governs the lens fit, of course, you have the physical, the RX as to the higher the power, the thicker the lens, and it is suggested that if you have higher power, you might want to also increase the LD. Okay, so far we're good. Okay, now as for altering, so if you want to alter, meaning to say you want to change, there's only two things I can tell you when it comes to changing. If you want to change the fit, for example, okay, if this is your, okay, if this is your cornea and this is your fit, if it's if it's steep, as we can see, steep. If it's tight, because the greater the sag height, the tighter it is, or the steeper the fit. Now, if it's steep, the two things that you can do is to change the base curve. So first thing you can think of is the base curve. Change the base curve. So if it's steep, what do you do? From steep, just make it flatter. Correct? Example, if this is I have 8.0. If 8.0 is steep, I'll just make it flatter. How do I make it flatter? Make it at 9. There you go. Now it's flatter. Or you want to change the LD. So that's your lens diameter. If I want to change the lens diameter to make it loose, I would reduce the lens diameter. If this was a 10, originally a 10, I will make it into 8. It will create a loose fit. Okay? From tight to loose. Do you understand? Do you follow so far? How about the others? I hope everybody is following. Okay, there you go. So that's what the sag height is all about. Clear? So there you go. So when it comes to the parameter, there are things that you have to understand. The total diameter, the lens diameter, or the overall diameter is essential. The BOZR, or also known as back optic zone radius, or your base curve. Okay? And then the center thickness is also essential. As to the higher the power, the thicker the lens. The optic zone diameter, where the power is. The water content, the higher the water content, the more permeable it is. The lower the water content, the less permeable it will be. Material selection, of course, such as you have a silicon, hydrogel, or even PMMA for RGB. And the method of manufacture. Okay, this, as I've said, this is how you get your total diameter or total lens diameter, TLD, OAD, LD, is by adding 2 millimeters to your HVID. Given I have 10, for example, I have 10 millimeters HVID. So all I do is add 2, and this will become 12. So 12 will be your lens diameter of choice. Okay, clear so far? But this is a range from 2 to 2.5. So I have 12.2, 12.5. So these are all accepted lens diameter, which is for soft contact lens is irrelevant. Why? Because of the softness, the pliability. It will conform to the shape of the cornea regardless. Do you understand what I'm saying? Okay. Now, so you have this. I'm sure you have done that when you are measuring the HVID. So this is for your pupil size. Now the diameter using, of course, the effect of the sag height. Rule of thumb, I need you to understand this. For every increase in your lens diameter, you should increase your base curve. Okay, I'll give you an example. Okay, for example, this is 12, meaning to say your HVID is 10. So if you order a contact lens, you must look for a 12 to 12.5 LD, correct? Do you follow? This is good. What if the available is 13.5? This is available. Is it okay? Yes, it's still okay. All right? It is okay. But according to the rule, for every zero point 0.5 increase in LD, you have to increase your base curve by zero point 0.3. So assuming earlier our base curve was 8, correct? If I have an 8.0, so as you can see, I have a 13.5. Coming from 12.5, there's a as you can see, one diopter increase, or one uh, m increase. So what do? So for every point 0.5, you increase by point 0.3, but there are 2.5s. Because from 12 point given, you have a 12.5. 12.5 plus 5 is 13. Okay, so 1.5. There's 1.5 here. Point 0.5. Okay. Plus another 5 because our available is 13.5. So another point 0.5. So total of 1 millimeter. So for every point 0.5, you are to increase by 3. So you have 2. So you have 3, 6. So because you have a base curve of 8, so since you change your LD, you need to change also your base curve from 8.0, increase it by 6. Where did I get that 6? 3 plus 3 increase. Do you get that? Why? Because the larger the diameter, the tighter it will be. For me to loosen that, I need to change the base curve. That's why I added zero point 0.3 for every. Because 8.6 is flatter than 8. The lower the value, the steeper it is when it comes to base curve. Correct? Do you follow? All right. Very good. Any questions? Any questions? Okay. Now, we use a fit factor. A fit factor is zero point 0.3 to zero point 0.9. Okay, understand that. So 1 millimeter to average K. For diopter flatter than average K, we're in, we add zero point 0.7 or more to the flat K for the less flexible material or thicker or low water content. Zero point 0.3 to zero point 0.6 is added for standard and flexible, thinner, high water material. Clear? Okay, good. Anyways, in reality, we have a manufacturer or a distributor that will provide us with a fitting guide. So, meaning to say, we may compute as much, but then again, in reality, they will make our lives easier by giving us the fitting guide. Are we clear so far? Joyce, are you still there? I need someone to talk to.
Yes po, Doc.
All right. Okay. Because I cannot see anyone. Even you, Joyce. Okay. Let's go. So that's your fitting guide. Next, as you can see here, more significant in thicker, less thicker, but less inflexible lens. Because as we said, it will only conform to the shape of the cornea anyways. Okay? So, use trial lens from the center of the base curve. And if no back optics or back optic zone radius or base curve options available, always look for a back vertex that is closest to your ocular RX. So in reality, you can only do so much, especially when it comes to contact lens. Unlike spectacle, you have to be specific. But contact lens, the deal is you always have to tell the patient, I will give you something that is functional. What does that mean, Joyce? Functional. Something that you can use. It may not be super clear, but you will function still. You will be able to wash your clothes, see images, do things. But it's not going to be as clear as probably if you're wearing eyeglasses. Why? if you would give the closest. But if you would give the exact RX, of course the patient will see clear. As a matter of fact, Joyce, contact lens is better than spectacle or eyeglasses. Patients usually would always say they see clear with contact lens rather than eyeglasses because of the vertex distance and all the pluses of contact lens. Are we clear so far? Okay, so that's a little of that uh, survey. So soft lens, fitting stock lens range usually 2 to 4 base curves for each diameter. Such as, guys, were you able to order from Doc Sherwin the RGP already? Is that a yes, Joyce? I cannot
Yes
see
po,
what's
Doc.
happening.
May 50 lang po na estudyante po yung in-accommodate po ni Doc Sherwin po.
Ah, okay, okay. All right, thank you. So this is the sag height we already talked about. We discussed this earlier. We already know this. Okay, and then for trial lens, as you can see, always look for the nearest vertex corrected spectacle. That's why you compute. Remember, that's why you have your LP computation, right? Okay. Next, if optional, select thickness based on back vertex power, DK over T, intended application, whether daily wear, extended wear, frequent wear, duration of intended wearing period, durability, handling, etc., etc. Now, if thickness is standard for series, ask, is the DK adequate for its intended use? Meaning to say, Joyce, if I would go for a thickness, I am already thinking of hypoxia, correct? So I want to know, how long am I going to use this? It's just like saying, how long am I going to wear the mask? Am I going to wear it long? Because I'm already thinking I cannot breathe anymore. Okay? How well would the lens uh, how well will the lens handle? So I need to also know that. That's why you need to be interactive with your patient to know what is the purpose of having contact lens. What are you it's like you need to also not just like give contact lens, you need to ask, are you going to use this for a long time? How are you going to use it? And then here is a thickness description when it comes to minus lenses, because minus is thicker peripherally against a plus, which is centrally. So again, what are you looking at? Of course, you're also still looking at hypoxia on the periphery. That's number one. Tension over the lid, number two. And the fit, of course, and the comfort. Um, Again, thick lenses move more than thin on eye behavior, not necessarily directly related to the lens thickness. It affects the profile or design of thickness, wherein it is irrelevant when it comes to soft contact lenses. Usually defined by your front optic zone, usually 8 to 11 millimeter. This is your optic zone diameter selection. Must take pupil size in photopic and scotopic. That's why we take two ways, dim and normal illumination. Okay. The RX may influence choice, larger if RX is low, smaller if RX is high. Which one is high? The optic zone diameter. Is the optic zone diameter equal to your OAD?
Hindi po, Doc.
If it is a monocurve, the answer is yes. Okay? Because in a monocurve, okay, your base curve and your peripheral curve is one. But if you have a pi curve, So this is your base curve, and this is your frontal curve. So it will change in one, two, three, one, two, three. So this is the base curve, base curve, secondary curve, peripheral curve. Follow so far? Okay. So again, for the optic zone, for the front, this has an effect on the lid. It's more on the lid. Okay. So it says here less movement when it comes to smaller, more movement when it's larger. We're talking about optic zone diameter, guys. We're not talking about the overall diameter. Please bear that in mind. Bear that in mind. We're talking only of the front optic zone diameter, not the whole total lens diameter. Okay. So the higher the power, the higher water content. Why? Because it's thicker. You want to compensate. So the most that you can do, make it high water content. Now, low power, you can do away with low water content. Okay? Final choice is a compromise between which one is more important, the oxygen permeability or the handling and durability. So that's one thing that you will have to compromise eventually. Now, soft lens fitting affect the changing of water content. As I've said, the greater the water content, the more permeable it will be. But then again, it will be softer, of course, the more water, right? So when it comes to durability, I believe the lesser the water content, the more durable it will be. Lens thickness is more thicker for high water content. Deposit resistant, unfortunately, it will be more deposit resistant if it's low over high. Next, these are the following methods of manufacturing: spin cast, molded, and lathe. Okay. Fitting lens rigidity depends on chemistry, method manufacture, water, thickness, and other. This is pretty much self-explanatory. Soft lens fitting, another self-explanatory. When you say lens rigid, it's less hard, right? When it's less hard, then it is most likely thinner with more water content, right? And this is spin cast manufacture. To compare with harder, which is thicker, lathe cut with low water content. For RGP, that would be materials with MMA. For soft, also we have methyl methacrylate and polyvinyl acrylate. So next, patient's data required, lens choice, HVID, K readings, spectacle RX, vertex distance, and interpalpebral aperture. This is self-explanatory though, right, Joyce? HVID,
Yes po, Doc.
lens diameter. Case, base curve. Spectacle RX, LP. Vertex distance, LP. Interpalpebral aperture, fitting. The smaller the palpebral aperture, the smaller the contact lens should be, right? As simple as that. Empirical is what you call when you're just computing things. When you say empirical, you're just calculating things without actually fitting. It's like estimation, Joyce. So you would do like 1 plus 1 is 2, 2 plus 2 is 4. 4 is already okay. I think it's already okay. That's your empirical, right? So no trial lenses required, cheaper from manufacturer, no lens maintenance, no public health issue because you just order. I think 4 is already good. But once you try, you would notice that patients do not experience lens wear before delivery. And then the patient would say, ang sakit pala nito. And or practitioner cannot observe patient response from the get-go. So what you're doing is you ask the patient, come back for your contact lens dispensing. And then the time you're dispensing is also the time you're just assessing. So that's the negative side or the disadvantage. Practitioner seem to be abdicating kasi ayaw mo nang mag-fit-fit, ayaw mong mapagod, or ayaw mong mag-invest. Ayaw mong bumili ng trial RGP. Gusto mo na lang, bili mo na lang kung ano yung contact lens ng patient, kung anong measurement, yun lang. That's abdicating responsibility. And then the accuracy of outcome is a big question. Fit is more complicated than just HVID and K reading. That's the truth. Remember, I gave you an example wherein our clinician would measure the K reading, and based on the K reading, they would prescribe any contact lens, particularly RGP. And they would say, oh, doc, how come I computed naman the K readings, but how come it's so flat or it's so steep? Because remember, what do you think they missed out? They missed out on something. And what is that? The K reading is is done perfectly to 80. Exact naman. Pero hindi kinonsider si lens diameter. Remember, for every 0.5 increase in lens diameter, you need to increase also your base curve because it will be tighter. Or vice versa. If you remove zero point 0.5, it will be loose. So, what do you do? Hmm. So, that's the understanding. You have to always compensate. Clear so far? I hope so. Soft lens fitting, a trial lens, of course, allows you to feel. That's why, in a nutshell, Joyce, it is. If you ask me, it's always better to try. Because if you don't try, you will never know, right? But if you try, you'll know. So it's so much better. It allows the feel, the patient can experience, the patient's reaction is assessed right away, and then you can assess right away also. So again, um, there's always pros and cons. Now, soft lens fitting trial settling. Always remember there's a set. It settles from the word settle. It's like this, Joyce. When you wake up, what's the first thing you do?
Nagsi-CR po, Dok.
Ako hindi. Ino-open ko muna yung eyes ko. First thing I do is to open my eyes. Tapos look around. Okay, and then I get up. Nagsaset muna ako. Nagsasettle muna ako. Hindi pagkagising ko, oh, sabay tayo na kagad. Open ko muna eyes ko. Pag na-open ko na yung eyes ko, titingnan ko yung time. Ah, early na naman ako. Okay. 2 o'clock pa lang, gising na ako. Okay. Yan. So the first thing I do is open my eye. And that's how you set. So settling period normally is 5 minutes. Okay. But it's a case-to-case basis. You can even have further assessment for about 3 to 4 hours. It's a case-to-case basis. Okay, fitting would assess during trial lens. Of course, the 4C. Randale, I taught them the 4C. In soft contact lens, SCL, we have the 4C. 1, 2, 3, 4. First is coverage. Next is centration. Next is clarity or comfort. Comfort. Last, clarity. Okay. Doc, can I interchange? Yes, you may interchange. Hindi naman to masyadong strict. Kailangan ito lagi number one. Oh, you can interchange. Because I'm looking, it's like what I'm saying, Joyce. Think outside the box. You can do this naman eh. And then, as long as you do all of it, It's still good for me. Do you understand? Do you have any questions so far? No questions, Joyce?
Wala po, Doc.
Okay, okay, okay. Okay. So there you go. Primary gaze. Yan. Yan. Lateral gaze. Okay, observe decentration, add lag, primary gaze. Point 0.2 to 0.75 or point 0.2 to point 0.7 is acceptable decentration. Why? Because it is decentrated for sure. Probably nasally. If this is your cornea, your contact lens may be decentered nasally or even temporally or even inferiorly as long as it's point 0.2 to point 0.7. I'm good. But if it goes beyond that, that is not good. Clear, Joyce?
Yes po, Doc. Clear po.
Okay. Up gaze and lateral gaze. Only one number I'm looking at. So, as simple as this. So, when looking up, I will create a lag. Okay. The contact lens did not follow. As long as it's 1.5, it's okay. Looking to the left. Okay, this will be my cornea. Contact lens will lag. As long as it's 1.5, it's okay. You go beyond that, is not okay. Are we clear? Are we clear?
Apo, Doc.
Okay. And then, of course, need for coverage, of course. This is self-explanatory. Nothing much to talk about here. Mechanical prevention, corneal trauma. Okay, we're good on this. Physiological, of course, you don't want corneal exposure. You don't want corneal desiccation. From the word desiccation, I think you already know that. If it's desiccated, it means your cornea is affected. And it's just as simple as understanding. It's not good for the cornea to have desiccation. Tear film, disturbance, lens and eye wettability. About 1 millimeter symmetrical overlap is ideal. So the overlap, as I've said, for example, if I have a 10 millimeters, the ideal is 12. Remember? Point 2 eh. 12 millimeters. So 1 millimeter here, 1 millimeter here. This should be the ideal. Correct? Okay. That's your 1 millimeter symmetrical overlap. Okay, too steep, it means not good a fit. Vision is clear immediate after blink. If it's too flat, vision is blurred immediately after blink. Why? Because as simple as this. Take a look at this. Okay. If it's too flat, wait. Let's change it. Okay. Okay. If your fit is too flat, there you go. What happens? Based on this premise, vision is blurred every after blink because as you can see, every after blink, this one will keep moving. So if this is the center, which is the OZD, which is where the power is, if it moves, it goes down, then your axis is now on the periphery. That's why you don't see clear every time it moves. To compare with a steep fit, every time you blink, this pushes the contact lens near the cornea. That's why the plus lens that is created under is pressed down to almost nothing, and that creates clarity. Correct? No questions?
Wala po, Doc.
Yay. Hey, Zach. Thank you very much. By the way, guys, Zach was amazing. He was uh, my assistant last week. He was a substitute teacher. Zach, congratulations. You did well. You made me so proud. I cried actually because I was so proud of you.
Grabe naman, Doc. Pero thank you, 'di ba may plus points?
Yes, of
Thank you,
course.
Doc.
Of course. Super, super impressed. Yeah. And so this is what it is after blink. It pushes the contact lens towards the cornea. And flat, it keeps moving, obviously. So again, movement, why movement is required? Because it removes and disperses ocular debris, promotes tear exchange, possibly aids in epithelial wetting by mucin spreading and smoothing. Okay, that's the reason why. Okay, so far that's self-explanatory. Soft lens fitting. Lens movement depends on lens type, of course, lens design, physical properties, fitting relationship, lead factor, and the eye topography, such as too steep, too flat. This is self-explanatory. Soft lens fitting assessment mobility, meaning to say the movement. So movement on blink, lag following eye movement as nasally temporally, movement up gaze as also when looking up, and your push up test, which I have shown you guys last time. So if conjunctiva is loose, edge indentation may be noticeable. So loose conjunctiva, meaning to say the covering, the membrane covering the sclera, right? Giving false impression of lens movement. Okay. So again, this is how it looks like. So I taught them the difference between dynamic and static. In soft contact lens, is Randall still there?
Yes, Doc, I'm here.
Okay. Static, dynamic. What's the difference? It's so easy. If it involves blinking, it is dynamic. As long as the patient is not blinking and you are not instructing the patient to blink, you're doing static. How do you do that? Like this. When you ask the patient, look to the left. Did you say blink? No. So you're doing static. You said, look to the right. Did you say blink?
No, Doc.
No. So what are you doing?
Static, Doc.
Very good. Look up.
Static pa rin, Doc.
Very good. Look up. Blink, blink, blink.
Dynamic na, Doc, kasi may
Dynamic na.
blinking.
Okay. So remember, when doing two things that's happening right away by looking up. Look up, blink. I would look at the going up of the contact lens and the going down. I am doing static and dynamic at the same time. So when I ask the patient, look to the right, did you say blink? In contact lens, when I ask the straight in your primary gaze, look straight, blink, blink. So I'm already doing dynamic, right?
Yes
But
po.
blink. But when I say, Anissa, when I say blink, hold, meaning to say stop blinking, I am now assessing static. Correct?
Yes po, Doc.
Super clear on that?
Clear po, Doc.
Yes, very good. So there you go. Primary gaze, up gaze. Is this acceptable? Yes or no?
No
No po,
po.
Doc.
Opo.
No, Doc.
Very good. Is this acceptable? Yes or no?
No din po.
No, Doc.
No. Very
Opo.
good. This is your push-up test. So what's the recording for push-up test? It's fast, slow, no movement, or the amount of displacement. Okay, if it's loose, there's going to be a lot of displacement, right? Now, ranking assessment method, lower lid push-up test, post-blink movement, lateral version lag, up gaze lag, comfort, and centration. That is your soft lens fitting ranking assessment method. If you should you rank it, okay, from the most predictive to the least predictive. Okay, what to assess during trial lens? Of course, regularity of retinoscopic reflex, regularity of keratometer Myers, and the effect of blink on both. So as you can see, it's not clear, right? So every time I would ask blink and then wait until it clears out. Okay, it means if it doesn't clear out, then my fit is not good. Correct?
Yes po,
Now,
Doc.
also, you can assess using stability of vision, Placido disc, Klein hand keratoscope, and your FSK. Okay. This I already told you this, right? So this should be easy. Is this something I need to explain? No need na. Alam nyo na yan eh. Steep. Pag taga-Lakers, steep. Steep. Joke, joke, joke. Okay, steep, tight. Okay, flat, loose. You want it normal. All right. So again, assessment of tightness, 100% bound, 40 to 60 is desired. With 0 degree, lens will not stay on the eye. Ease of lens push-up. Okay. What is acceptable post-blink? 0.2 to 0.7. We already said that. We already saw that. It's the same banana. Slightly less movement, acceptable with higher. Okay. We want it to move, right? Okay. So this is your ideal, and this is your tight, and that's the loose. So far, so good. This is so self-explanatory. So easy. So what is not acceptable? Curling or wrinkling. If your contact lens, as you wear them, ayun, nag-curl. Nag-curl na, ayun, nagpakulot. Yan, that's not good. Conjunctival indentation, meaning it's too tight. It's sucking. Nagkakaroon ng suction effect. Nagkakaroon ng, ayun, nagkaroon tuloy ng mark. Nagkaroon ng indentation, no? Ayan, ibig sabihin, napaka-tight ng contact lens nung suot mo yan. Nung tinanggal, merong indentation. Merong footprints. Does that make sense? Di ba pag umapa ka sa sand, anong nakikita mo? Footprints. Di ba? Okay. So you have your excessive decentration, excessive movement, and disturbance, of course. No movement. You have corneal exposure under any circumstances. Fits producing limbal perilimbal scuffing. You don't like that. Fits which result to blink-related visual disturbances. You don't like that also. So, excessive tightness. Do you want that? Of course not. It's not going to move. You won't have much blood flow. You will have indentation, of course, as I've explained earlier, low-grade inflammation and vision better after blink. So that's what it is. Yeah, we're describing it. So it is useful to remember that on eye, dehydration tends to tighten the fit. And this is what you call, Anisa, pervaporation. Correct?
Yes po, Doc.
Okay. So there you go. Now let's learn about loose. Alam na natin yan. Kung alam mo ang steep, you will know the loose. Correct, Anisa?
Yes po, Doc.
Kasi ops lang yan lagi. Correct? Oh. Kaya no need pang i-memorize yan. Ops. Diba? Am I right? Okay.
Yes
Inferior
po.
lens lag, even primary lens. Of course, because it's loose nga eh. Kaya nalalaglag due to gravity. Lens may slip of the cornea. Of course nga, maluwang nga kasi. Subjective discomfort. Oo nga, ang galaw kasi. Di ba? Parang self-explanatory naman to. Hindi naman, kahit nga anak ko, naiintindihan to eh. Go. Next. Tint selection. Handling. Full diameter. Light tint. Avoid halo. You have your iris diameter. You have eye color enhancing. So again, there's two things that you can think of under tinting. There is what you call tint for enhancement. Meaning to say, what's the color of your eyes, Anisa?
Dark brown, Doc.
Brown. Mag-contact lens ka ng light gray. Yan. Makikita mo, mag-iiba, pati looks ng face mo. Magmumukha kang awu, awu, awu. Diba?
Totoo, Doc.
Totoo yan. Totoo. But, there is also what you call handle tint. Pag sinabi mong handle tint, yung contact lens has a color so that you can differentiate left from right. Yung left gawin nating yellow. Why? May L dun eh. Hindi mo makakalimutan. Yung right gawin kong red. Ayan. Pero red ba talaga to? Hindi naman red na red to. Ano lang to? Pag nilagay mo against white background, may kita mo, parang yellowish siya. Parang reddish siya. Pero pag sinuot mo, hindi naman makikita yan ng pasyente, ay ng tao, no? Do you understand what I'm saying? That's your handling tint. At pag nalaglag ang contact lens, dahil wala siyang handling tint, makikita mo, hindi.
Hindi, Doc.
Very good. Kasi nga, wala ngang tinting. Kaya dapat itint mo para pag nalaglag, ayun o, medyo bluish. Nakita mo differentiation niya. Kaya, ayan si handling. Okay ba tayo doon? Okay ba yun? Alright.
Yes,
So, ayan
Doc.
si enhancing. Na-explain ko na yan. O yan, oh. Parang ikaw, Anisa, oh. Anisa Metropia. Anisa Coria. Yan. Very nice. Okay, cosmetic opaque lens. Very nice. Right? Okay. Now, soft lens fitting, final decision required. Your total lens diameter, if optional. Your base curve, if optional. Back vertex, compromise if astigmatism present. Thickness, if optional. Tint, if any, whether it be handling or cosmetic or even opaque. What's the difference between prosthetic and aesthetic? There's a prosthetic contact lens. Prosthetic. Yan. Yan. This is the first subject I taught when I entered school. Because of my dentistry background. Because we make postizo. It's called prosthetic. Diba? Oh, prosthetic. It's fake. That's why prosthetic is hiding something such as probably cover up. Diba? Merong opacity, you wanna cover it up. Merong deformity, you try to hide it, prosthetic. Against cosmetic. Si cosmetic, pampaganda yan. Kaya yung mga girls, alam na alam yan. Cosmetic. Correct? Anisha
Yes
metropia.
po.
Okay, very good. Anisha metropia. All right. And that is your opaque to cover up. Now, soft lens final decision is your yes. Yes. Crystal, what can I do for you? There you go, Randall. You know, Randall, you missed something. The last time I went online, there was an individual who turned on her microphone and
Doc,
started partying. Mm. And
Doc, napindot
even,
lang po. Sorry po.
okay, Randall, are you still there?
Yes, Doc, I'm here.
And you know what happened? While I was talking, it's like a minor bird. Oh, say something. For example, Randall, you try to do the lecture. I'll show you how it was. Go ahead, talk. Say something, anything. Make kwento.
Soft lens fitting,
Silence
final
feeding.
decision.
Yeah, like that, mockingly. I experienced that last time. Can you imagine? How does that feel? Does it feel good, Randall?
No, Doc.
Okay. All right. Lastly, for soft lens fitting summary, a well-fitted soft lens combined with a program of disposability and or good care system is proven formula for success. So meaning to say, if you try to be careful in getting all the parameters correct and the design correct with a good program of how to dispose, whether it's one day, that's why Randolph would like the one day or the dailies, so that right after that you can throw it away, or a good care system, such as how to take care of the contact lens. Um, Rika, are you there? Can I share?
Yes, Doc.
Can I share about the contact lens that got dried up? So there was a
Yes
question,
po.
right? You asked me, is it still good? Actually, it's not good anymore because the parameter is already changed. Remember, in soft contact lens, if you are not going to use it, you need to soak it right away. And you cannot afford to make it dry up. Even though if you soak it again, it will soften again, but the shape is already altered. That's why we don't subscribe or we don't allow the soft contact lens to dry up in a container. Are we clear? That's why it's always better that you use daily disposables. All right. Do you have any questions so far? No questions?
Wala po, Doc.
Thank you. Randale, Anissa, thank you very much. Randale,
No questions, Doc. Thank you
very,
very much.
very good. How about Joyce? We're good?
None so far po, Doc.
Yay. Zach, my buddy.
No questions po, Doc.
Okay, good night, everybody. Thank you. Take care.
Thank you po,
Thank you,
Doc.
Doc.
Enjoy
Bye, Doc.
dinner.
Thank you po. Thank you po,
May dinner
Doc.
po.
Enjoy.
Thank you so much, Doc.
Enjoy.
Thank you po,
Hi.
Doc.
Hi.
Po.
Hi. Good night. Good night. Good night.
Good night po.